You cannot afford to be sick. It's a luxury to take time off. You're less likely to see your GP.
Mm-hmm.
Likely to get worse.
I think in healthcare, it's very easy to make the argument for health equity rather than so much than equality.
Stories, labels, misconceptions. NHS remains a blessing. Created in 1948. We want it to remain great. A podcast where we share our stories, explore solutions in all their glories. They say it's broken, but it's not done. With your hosts Val, Barrett, and Dr. Jeremy Anderson.
Welcome to Stories, Labels and Misconceptions, co-hosted by Val Barrett.
I'm Dr. Jeremy Anderson.
We are continuing our health inequality series. Today is part 3 and episode 1 and 2. What did we talk about?
In our first episode in the series, we talked about what health inequalities are and why they persist. Health inequality is really about the unfair and controllable factors that result in differences in health between groups. And in episode 2, we talked about specifically the social determinants of health, how things like that aren't health directly related, but things like housing, income, education, things that we don't normally think of as being related to health actually contribute to health or ill health long before you reach a hospital.
Yeah. We're going to briefly just tell you about the 2010 Equality Act and the population groups commonly considered for health inequality. These are the protected groups.
Okay.
So the protected characteristics are age, disability, gender reassignment, marriage and civil partnership, pregnancy and maternity, race, religion or belief, sex, sexual orientation. So those are the protected characteristics.
Right.
Inclusion, health and vulnerable groups, Gypsy, Roma travelers and boater communities, people experiencing homelessness, offenders, former offenders and sex workers, socioeconomic deprived population. This includes wider determinants like education, low income, occupation, unemployment, housing, and geography, population composition, environment, social connectedness, and features of specific geographies such as urban, rural, and coastal.
So the first 9 characteristics from the Equality Act, it's illegal to discriminate on the basis of those things.
It is. Yes.
It identifies specific vulnerable groups.
Yeah.
And then it talks about factors that contribute to disability, vulnerability, or unequal.
Yeah, just like we discussed last week.
Okay.
Not all inequality looks the same. Some of the worst health outcomes in the UK are shaped by who you are, where you're from, and what your body has been through. In today's episode, we ask who gets left behind and why. We'll look at health inequalities through the lens of race, disability, and class. This is more than statistics. It's about structural exclusion, lived experience, and what needs to change. The first part is about race and equality. Dr. Jeremy. We touched on it a bit last week or the week before about Black women in childbirth.
Okay. Black women 3 to 4 times more likely to die in childbirth.
Yeah.
There's a link between being Black and more likely to die in childbirth. We're not saying there's a direct causal link. We're not saying the amount of melanin in your skin causes you to die. We're saying there's other factors related to those things that result in the connection.
Yeah.
So it's like we need to be detectives to try to figure out what are the factors that are related to, what are the factors that make this phenomenon, right? So what is it I assume these statistics are from the UK. So
Yeah.
what is it about being a Black woman in the UK that results in a higher rate of childbirth or of death in childbirth compared to other groups? What are the things that contribute to death in childbirth?
They're saying it's systemic bias,
Mm-hmm.
language barriers, and medical racism
Mm-hmm.
play a role. As a Black woman myself
Mm-hmm.
who has given birth,
Mm-hmm.
I personally haven't experienced this. That's about me.
Mm-hmm.
Not to say that it doesn't happen, it does, because the statistics are
Yeah.
telling us that.
Yeah.
We know that certain ethnic groups
Mm-hmm.
have higher rate of diabetes, high blood pressure,
Right.
heart disease, or lower cancer screening uptake.
Yes. Specific populations of people have different base rates of a particular illness or condition. That's not really a matter of bias. That's just the starting point.
Yeah.
But when we talk about bias in the system, we're talking about a system that isn't perfectly attuned to the needs of the people in the system, or at least certain groups of people within the
Certain
system.
groups, yeah.
If you have a group of people that have a high rate of a particular condition,
Mm-hmm.
if the system isn't sensitive to that or isn't meeting those needs,
Yeah.
there's a problem, right?
They like to say that this group or certain groups, but let's stick with this group, don't access services. But what
Yeah.
if that service isn't accessible to that person's needs?
Yeah,
Do
I
you,
mean,
do you see what I mean? Because I
exactly.
myself have tried to access services. I know where they are. There's no language barrier for me. Yet I've had problems. There always seems to be a barrier.
What is the barrier? Just saying that Black women don't access the system.
Yeah.
Why aren't people accessing the system? What creates a barrier to access?
I've always looked at this word access and accessibility.
Mm-hmm.
When I read their reports, the onus is always on the person, on that particular group. You haven't accessed us. So
Correct.
how can we provide a service to you?
Mm-hmm.
Or you're hard to reach because you're hiding, which Lutely read. So it's as simple as that. We know there's a shortage of places, whether it's mental health, housing, or whatever service it actually is. But when we come to pregnancy, we know at the end of that, you're going to have a baby.
Yes.
So you've got to access something. Do you know what I mean? You've got to be known by someone. So whether it's your GP, midwife, what else is there? Hospital appointments, clinics. There's always a stage throughout those 9 months.
Yes.
How can you not be accessing? I remember 32 years ago, I didn't know I had sickle cell trait until well into my pregnancy. Things can be missed. Even in the borough where it was policy, everyone got tested. My GP said, we don't know how you got missed. Some people do fall through the cracks.
Yeah.
I was visible. I was being seen. If I can fall through the cracks where A, there's no language barrier, I'm in communication with my GP and a midwife, going to all my appointments, why then does somebody like me still fall through the cracks? Because if that can happen to me, how are they supposed to reach out and provide a service to those that they see, quote unquote, hard to reach, quote unquote, not accessing care? How is it that two women going in, both pregnant, same age?
Okay.
So why is it that the Black woman is 4 times more likely to die during childbirth than a white woman? Because that part doesn't make sense to me. They're both going in for the same thing,
Mm-hmm.
to give birth. It is not exclusive to
Right.
one group over another.
I don't think that number refers to all things being equal. Black women are 3 or 4 times more likely to die in childbirth. They're saying given factors are not equal, that's the. If you compare 2 women, one black, one not, what might be a difference? Let's say one of those women had a bunch of extended family and other kids, nieces, nephews, cousins to look after. Both pregnant, but one's got a bunch of other responsibilities, makes it harder to attend appointments.
Yeah.
For example.
Okay.
That could be one factor.
The outcome shouldn't determine that. You leave alive with your baby. I never went to mother and baby groups, but I came out alive with my child. So wherever that person lives, how they live, whatever health condition they have, doctors keep notes. But it still shouldn't determine why that woman should die during childbirth.
Yeah. So, Val, the numbers you've looked into, do they talk about the cause of death? When women die in childbirth, I don't know what people are dying from. Are they hemorrhaging, bleeding, or are they having heart attacks? What is it that actually is the cause of death? Did the numbers say anything about that?
Well, it's
what are the
mentioned here,
factors that are contributing to this? Preeclampsia. Okay.
blood pressure, which we mentioned, because we
I can say a little bit about preeclampsia. Before working in sickle cell, I did volunteer work for a charity related to obesity. And one of the things that I did for them was I developed a training manual for midwives working with obese pregnant women. And they talked a lot about preeclampsia. As a dude who's never given birth, I was maybe not the first choice for this role, but it did give me the opportunity to do a lot of research and learn. Preeclampsia refers to when an embryo doesn't fully implant into the uterus, and a number of different effects on the way that the embryo or the fetus develops. It causes blood pressure spikes, which can be dangerous or fatal to both the mother and the child. There's a few different factors that increase risk of preeclampsia. One of them is obesity. So the higher your body weight is, the more likely this is to happen. And I'm not sure if there is a higher risk of preeclampsia in Black women compared to women of other groups. But if that's the case, that's one factor, just as one of those base medical factors that could account for different outcomes.
Some also say things like medical racism. I've never heard that before.
Yeah, I think you and I are both of a generation where, like, when someone talked about the word racism, what they were talking about generally was like overt racism. People who just said, I don't like that group of people because of the group they're in. That's overt negative attitudes or behavior towards groups of people. But I think that kind of racism has attracted an enormous amount of stink. It really is just a reputational murder to accuse someone of that kind of racism. Over time, we recognize that's not the only kind of discrimination or negative impact of these types of attitudes. They're more subtle. So just that white pillar cases and burning crosses kind of racism. But over time, the structural inequalities are often referred to as racism. I know what they're getting at. In my view, I think we need a different word for it, because when we talk about organizations being racist or medical systems being racist,
they use institutionalized
racism, right? There's people that this isn't what it means, but people are afraid what this means is that the people in the institution are that kind of old-timey pillowcases and burning crosses kind of racism, and people freak out, say, "Oh, no,"
dismiss it.
And so we spend an enormous amount of time trying to calm people down and say, no, that's not what we mean. We're saying the system isn't aligned perfectly to different groups.
You
That's
know, like
what we're saying.
for example,
right?
Louise Casey
Okay.
wrote the report about the Met. All these things she wrote, they objected to the racism. It's amazing how people, we're not racist, but we ain't racist. She wrote that report and they will fight tooth and nail. That one word really gets up people's backs.
Exactly. And in some ways, that's a good thing, right? Like people, if there's one thing people don't want to be, they don't want to be racist.
No.
Great. That's an improvement. That's a change from decades past.
When a woman goes in to give birth, she just wants what she's going to get.
Yeah.
She wants to be listened to and heard.
Yep.
A lot of Black women say they are not listened to and heard, and they're not seen. Those are issues. The system itself, the NHS, is supposed to be equal throughout. Having a service that says, yes, we are going to provide equal care for all patients. I'm just saying providers, when faced with someone that doesn't look or sound like them, if we can provide a service that doesn't always dictate chapter and verse and say to clinicians that because of you and your system, this create barriers for such and such a group. What, on the flip side, what does that do to the service providers? How does that make them feel? That these reports are written about the system can't work without people. People are the system. People make up the NHS. And I believe everybody wants to provide the best care.
Yes.
Nobody wakes up one day and says, I want to be a nurse, I want to be on my feet, tired out 24/7 with very low pay. I don't believe that. But there's something outside of their control that's built in the system to be unequal.
And if we apply the same thing, say, to pregnant women, right? If there's a risk that Black women have in pregnancy that isn't recognized just because of a lack of familiarity, it's not a kind of racism on the part of the doctor. It's just a lack of familiarity. You're not recognizing, oh, these people are at a higher risk of whatever it is.
We have an example of a story.
Yeah.
It's about Nima, a Black British woman in her early 30s. She was 6 months pregnant and went to A&E with sharp abdominal pain. She told the nurse she had complications before and was worried it could be early labour. The staff dismissed her concerns, saying it was likely just anxiety. Hours later, she went into premature labour, alone, in pain, still waiting to be seen. Amina survived, but her baby didn't. She later found out Black women in the UK are almost 4 times more likely to die in childbirth white women. This is according to Embrace UK, and these are figures for 2023. The maternal mortality for Black women is, as we said, 27.8 deaths per 100,000 compared to 6.6 for white women. Reasons include, as they said, medical racism, lack of listening to patients' concerns, and inadequate care pathways. So Amia's story isn't about fear. It's about routinely being unheard in a system that wasn't built for her voice. So I know from watching this program that many women feel like that.
Yes.
Many do. And to flip the coin, some white women also feel that way. But the figures of dying in child are more dominantly for Black women. But we know that class can also play a role when it comes to white women. Yeah. Okay. let's move on to disability.
We're talking about different kinds of disability. Something close to my heart, given my occupation, is the level of mental health services in this country. Just to take the most stark example, is someone with schizophrenia who suffers from delusions and hallucinations. They're fluidly psychotic. That person is disabled. They're not able to think properly, and they're not able to function. So that would clearly be a source of disability. Yeah.
I know, Dr. Jeremy, there are so many different types of disabilities. But for this episode, this section, we're just going to focus on people in wheelchairs, because people don't seem to think about wheelchairs, accessibility.
I can think of a woman, we'll call her Renee. She was an elderly woman who had mobility problems, used a wheelchair, but so she couldn't go up and down stairs, but lived on the 4th floor of a high rise. As a result, she was housebound. She often couldn't attend her appointments. If she did need to leave her flat, she had to basically call an ambulance or firefighters to carry her because the lift wasn't working. If someone can't leave their building, they're probably not going to attend healthcare appointments. Even if they attended, people in wheelchairs need access to the tubes. Some tube stations have lifts, but not all tube stations have lifts. They're supposed to, but but it's not going to happen for decades.
Because don't forget that these tube stations are very old. The
way the law is implemented, where they have to have lifts, is they install the lifts when they're going to renovate the station. They have to install lifts. But many stations they haven't renovated yet don't have lifts. So some stations have them, some don't. So you have someone who it's difficult to get out of their building, travel around their city. And once they arrive at their NHS GP clinic or hospital, those buildings may also be very old, may not be wheelchair accessible. Disabled adults in the UK are twice as likely to report bad or very bad health compared to non-disabled people. That comes from the difficulty they face trying to stay healthy, improve their health, and keep it. They can face longer waiting times or more canceled appointments. If they're not able to attend an appointment on a given day because of a disability that has to get rescheduled, they have a longer wait for services. And it means that when they do get diagnosed with things like cancer or other things, they get diagnosed late. With the later you catch it, the worse the outcome. One problem with working remotely, so I see a lot of patients virtually and remotely, and so that actually can really help with people with mobility problems, because if they can stay at home, they can have a session where they see someone by video. But if that's not the only source of disability, if you have a visual impairment, using audio-visual media like a video call isn't an option. If you communicate by Braille, a video call isn't an option. The more disabilities you have.
A Freedom of Information request revealed that only 35% of NHS trusts fully comply with the accessible information standard, meaning a large majority are failing to fully implement it. This standard ensures accessible communication support for people with disabilities or communication needs.
That's a good example of, we can pass the law or set the standard, but that doesn't necessarily mean institutions are going to meet the standard. Yeah.
We know that. Some of them are not worth the paper they're written on.
Yeah.
Something just by having a bigger toilet, it's wheelchair accessible. There's nowhere to change anyone if somebody's wearing what's it called? A colostomy bag.
Colostomy bag, yeah.
All of those things. They just think just by providing a bigger space, that is it. It's a bit more than that. Do they have disabled people helping them design these things? That's the thing. Or do they just go by, we've just got that space there for a baby? Disabled loos are not really just about changing a baby. Do you see what I mean?
Exactly. That is the changing face of
Yeah.
healthcare, where a lot of conditions that used to be fatal are now chronic. They're managed, but it means people have specific needs like colostomy bags or peritoneal dialysis. It means people are carrying a lot of stuff and they need access to non standard toileting facilities.
Not all clinics are wheelchair accessible. Some hospitals are very old and they
Yes.
haven't been refurbished. So imagine you are wheelchair bound, you know, and you have an appointment. They sent you to a specialist clinic, but there's no wheelchair access.
Yes.
You can't make that appointment because all these letters that are given out, they're standard.
Hmm.
Your appointment is at blah, blah, blah. Is it considered for people that are blind, in wheelchairs, with learning disabilities?
Yes, that's another thing that isn't appreciated is people with learning disabilities or specific cognitive deficits
Yeah.
that maybe they didn't have before, but they develop over time, sometimes in dramatic fashion, as in the case of a stroke. But even if they haven't had a specific acute event, there can be a gradual decline or subtle damage over many years, so that people who were had some capability before are gradually losing that capability. And if it's not detected, then what happens is we're trying to interact with people in the same way as before, but they're not responding as well. We don't know why, and probably just blaming them. And what really needs to happen is that we recognize that a deficit has arisen, and we need to provide people information in a different way.
Yeah. You provide the information, but also have the facility and the resources that person needs once they get to their appointment.
Yes.
How are they going to get there? Do they have a carer support, somebody to bring them in? Are they fully aware of what's going to take place? It could be a woman who's going to have a smear test, or she's got ovarian cancer or whatever. Does she
Yeah.
understand what's going to happen? Do you see what I mean?
Yeah.
Because we've got to remember these clinicians, they're specialised in what they do. They may not be specialised in working with people with learning disabilities,
Yeah.
working with the deaf, working with the blind. They
Yeah.
need those resources on site when needed.
Yeah.
Do you see what I mean? This group can have a better health outcome because we know the outcome for this group is low. They're less likely to speak up. They're sitting in A&E. They're less likely to shout out. Like some people will scream out. So sometimes when you're sitting there quiet, you are left behind. We know they face longer waiting times. A third of NHS trust. Yeah, we stated that. But yeah. So all the protected groups don't seem to be protected. They're all vulnerable, each and every one of them. And you think when somebody comes in, especially somewhere as busy as an A&E, clinicians need to think differently. It's hard. A&E is so fast-paced. People with mental health breakdowns, I've seen it.
Yeah.
People running after them. It's mayhem. It really is. I think people have to be more aware of these groups, people with disability. But I myself, as a carer, I advocate for my child. But I'm not around. I would want him to be seen and heard. Okay. So the example story. There's a man named Tom. He's in his 50s and he has a physical disability and he uses a wheelchair. He needed urgent follow-up after a cancer diagnosis. The hospital booked him into a clinic that wasn't wheelchair accessible. When he asked for a virtual or alternative appointment, he was told to wait another 6 weeks. By the time he was seen, the cancer had spread. He told me, I didn't feel like a priority, just a problem no one knew how to solve. Sadly, that feeling reflects the bigger picture. Disabled adults in the UK are twice as likely to report bad or very bad health compared to non-disabled people. That is from the ONS 2022. They also face longer waiting times and more cancelled appointments, especially for mental health and diagnostic services. And it says over 40% of NHS services still fail to meet basic accessibility standards. So Tom's story shows that when the system isn't physically or digitally accessible, people fall through the cracks or are left waiting while their health declines.
And I think when people have multiple health conditions or sources of disability, this often goes hand in hand with poverty or lower socioeconomic status. So maybe this is a good time to segue into section 3.
Class and poverty.
What do we mean by class?
I want this to show how income and postcode define health outcomes.
Right.
Living in a certain postcode, you'll have better resources.
Yes.
I live in the city. I live in SW10. And where I am, I have 5 major hospitals, 3 within walking distance, 2 I can drive to.
Yes.
One of them is a cancer specialist, the Royal Marsden. Then we've got the Royal Brompton. I went there for my lungs. Then you've got Chelsea and Westminster, and they're all on the same road.
Yes.
Then the other side of me, I've got Hammersmith, which is a designated heart attack unit. I went there when I was ill with my heart. And then up the road, we've got Charing Cross. So I'm in a prime position to get good health. When you hear stories of people having heart attacks and they're lying on trolleys, my experience was when I was having mine, my son dialed 999, paramedics came, examined me, they knew what it was, they called ahead, they were waiting for me at the door.
Right.
And they went straight to work. No waiting, no queuing.
I was going to say, so that is one of the factors that contribute to lower mortality or longer lifespan in more affluent areas that have those services nearby. Means when something happens, emergency services come, there is emergency service in the area, and it doesn't take long to get there.
Exactly.
What are the other factors?
Chronic illness starts earlier in low-income communities.
What we've talked about before with the different factors that contribute to chronic illness, including environmental exposures, occupation, stress, housing, lack of adequate nutrition combined over the lifespan to contribute to chronic illness. If you're exposed to more factors, chronic illness starts earlier. If you develop chronic illness and healthcare services are not available, you have poorer outcomes than people in other areas.
But also when you're living in a housing that's got damp and mold, have a young child, they can, what's it called, respiratory?
Yeah, there's a number of respiratory conditions people can develop,
And also people's jobs.
Yeah, if you work a job where you don't have as good of benefits, or if you're not working, you don't get paid, well, how often do you take time off to go to the GP for appointments or get an investigation done?
Yeah.
So,
Yeah.
so by the time people catch an illness, it's later,
Hmm.
and that tends to be more severe.
Yes.
You don't have as good an outcome.
Hmm. We know resources, housing, work,
Hmm.
unemployment, low income, asthma.
Mhm.
People with asthma want a low income and they're just over that threshold where they can't get free prescriptions,
Now
they
they,
pay.
yeah,
Now, if you have X amount of children and you got all the essentials to pay for, we know the cost of living is higher. We know that through the studies that Asthma UK have done, is that they are less likely to get their prescription. Therefore, their asthma gets worse. They're likely to end up in A&E.
correct.
Yeah. So we talked about cause and effect before. So even though the government cutting costs at one end and they think they're saving cost at another, it's down the road, it's moving it somewhere else. Yeah. If you're cutting in housing, education, or social care, and that impacts on families, that cost will go to the other part of social care. But then if social care is being cut because they don't have the workers, they don't have the staff, because they said they want to cut the amount of immigrants coming in
Yeah,
to do social work, then that cost then moves to the NHS.
exactly.
So all it does is it moves along. That's all it does.
It's
So
not,
they're not solving
it's,
anything.
no, it's not a real solution. The solution is to make people healthier,
Hmm.
right? To reduce those costs.
But in some cases, we're making people sicker.
Correct.
When you're working class, you can't afford to be sick.
Hmm.
If you're on 0 hours contract,
Hmm.
you cannot afford to be sick. It's a luxury to take time off. You're less likely to see your GP,
Hmm.
likely to get worse. And until you're at that stage where you really can't do anything, then you'll go to A&E. And some cases, as we know, people get diagnosed late, whether it's cancer or heart disease. Yeah.
Yeah.
So we know that structural neglect, underfunded GPs, longer waits, and fewer options. No options. When you live in a postcode, you don't have any options. I'm not in that income bracket where I can go private,
No.
but I do get better healthcare because of where I live, not because of what I earn or what I do. Do you see what I mean? So if they already know their data, their statistics are already stating that if you live in a deprived area, people are less likely to live beyond a certain age, more likely to be unemployed, more likely to be on disability. So wouldn't you think that's where the resources need to be concentrated, not taken away, not left behind? Every time there's a new government, they say we need to level up the north because
Yes.
it's always been left behind.
Yes.
And these communities where there's poor housing in the south as well. But when you have poor housing, poor resources, high unemployment,
Yes.
high amount of people having to claim disability, that would be the area where they really do need to plough. It's not just money.
Hmm.
Because let's say there is loads of money. It's where you distribute that money. Do you see what I mean? It's
Yes.
that money going to the correct places.
Yeah. So a concrete example of that would be the current debate with the winter fuel payments, right?
Yeah.
So older people get winter fuel payment, but some of the older people in society are some of the wealthiest. If you're a millionaire, do you need a winter fuel payment? Probably not. You can probably afford to put the heat on.
Yeah, but when we means test benefits, There's a cost. Sometimes that cost doesn't justify the overall, what am I trying to say?
You wouldn't want a system that costs more to implement than it saves.
Yeah.
If it's cheaper to give everyone the same amount, fine. But if you could direct funds to where they're needed, where people who don't need it don't get it, but people who aren't getting it but need it start to get it, obviously we're in favor of something like that.
Is it always fair to beat the wealthy? They've made something of their lives. Not all were born with a silver spoon.
No.
They've come good. They've made money. A lot of them give to charity, do a lot of good things.
Yeah.
Being fairer with the tax system. Because when you cut from the bottom, that only helps the ones at the top.
Yeah. I'm agnostic as to how we would want to do this. I'm not an economist. If you wanted to do it through a progressive tax system, I have no problem with that. These are political decisions. What kind of society do we want to live in? Do we want a society where everyone gets taxed or receives the same benefits equally? Or do we want to direct things where they're needed more? That's the difference between words like equality and equity. Those are not synonyms. They mean different things. Equality means that we actually treat everybody equally. And equity means there's various ways of describing it. And some people, the online debate, I think people are down on equity. It seems unfair. Like if somebody's getting something, I must be losing. But really,
you think that?
I'm not saying I think that. I'm saying the people who are down on equity would argue, they would say, I don't like it that you're getting something that I'm not getting because I feel like I'm losing. But it's not actually, that's not really it. There really are people out there who have needs that I don't have.
Yeah.
So if those needs get met, it is making up for a hardship. I'm not losing. In fact,
you're gaining. Society gains if people at the bottom are brought up.
Yeah.
When people at the bottom get worse, it's a bigger cost.
Absolutely.
I think it's a bigger. They may think they're saving today, but it's going to cost more tomorrow.
And I think in healthcare, it's very easy to make the argument for health equity rather than so much than equality, or at least equity in terms of where we direct the resources. We want to direct resources. We give people medication who need it. We don't just dole out the same medications to everybody, right? It's based on need. It's always been based on need.
Yeah.
In other areas, maybe the job market or other things, there's maybe a different philosophical argument. Does it make sense to say that everybody who wants to be, I don't know, an architect gets to be an architect, no matter how good at math they are or aren't?
We ain't good at math.
I'm not the best at math, not a good engineer. If I wanted to be one, spending effort making me into an architect, probably not worth it.
We can always say, I want to look at football. For example, you have these youth academies.
Yes.
All these young men and young girls going through it, but how many make it? A very small percentage.
I think sports is a great example, right? It's not an equity-based endeavor. We're really interested in who is the best at this thing.
Yeah.
That's all we want to see. As a spectator, you want to see the best people on earth doing that sport.
But when you look at football,
and
the majority of the players, they come from working class families. In this country, they do.
Yeah.
And then once they get to a certain level and they're earning a lot of money, they're moving their family out of poverty. Lifespan in football isn't long. How easy is it for someone unemployed for a long time to get on the employment ladder? It's hard.
Yeah.
When they say, go and get a job, it's not as easy as they believe it. I remember years ago, I applied for this job. It was working at a piece. Over 1,000 people applied for 2 roles.
Yes, exactly.
No one's going to read them.
I think that's only going to get worse. The workforce going forward is just going to be more difficult for people to have gainful employment.
There are gaps. Social care, we're always looking for nurses. But social care is where the gap's going to be.
Yeah.
So perhaps the government need to do more, make it more attractive, whether it's the hours, pay, career progression, but
Yeah.
it's got to look more attractive
Yeah.
for
I
people
think
to want to do.
wages have to increase to make that an occupation that people want to get into. It has to be built up in terms of status. It should be recognized as a high profile
Yeah,
occupation. It's an important job. We really do need it,
yeah.
whether we like it or not.
It's going to get bigger. We're getting
Yeah,
old.
demand is
You
growing.
might need
And
care. You
yeah,
never know.
absolutely.
I might
Yeah.
need care. The thing is, in Scotland and Wales, they have that register
Yes.
where people have to,
Yeah.
so it's seen more
Yeah.
as a profession. England has to go that way. They have to see it as a skilled job and they value the people that work in social care.
Yeah. So
Agree.
if we value it, we respect it, it's high status,
Yeah.
well compensated, I think that will
Excellent.
solve the problem. These jobs are very difficult to fill because we don't value them. If we made our pay scales a little flatter, high earners don't need to make so much more, and the people who are not making much could make a bit more, that would make a stronger society. I don't see why CEOs need to make a bazillion pounds, right? They can make somewhat more, but they don't have to make so much more, right?
And the bonuses.
Are you familiar with Ben and Jerry's ice cream?
Yeah.
Did you know how
I'd
salaries
like
work in that? How the salaries work in that company?
No.
They set a cap on the difference between the highest and the lowest paid person in the company.
Okay.
And I don't know exactly what the limit is, but it's something like the CEO can only make, I don't know, like 70% more than the lowest paid person in the company. There is a hierarchy. People do make more money as they
There's
progress.
always going to be a hierarchy.
There's always some hierarchy,
Always.
but it's flatter, right?
Yes, yes.
So what it means is the person sweeping the floors or doing the lowest level job
Yeah.
is making a really good wage compared.
Really? At Ben and Jerry's?
Yeah. As the company does well,
Everyone
and
does well.
everyone
Yes.
moves up.
Yes.
A rising tide floats all boats. Capping the salary of the higher paid people,
Mm-hmm.
leaving more money for the lower paid people means everyone comes along as the company prospers. I think something like that in society would be helpful in addressing a lot of problems we're talking about.
We can't do anything about class because we don't have
Well,
a classless society. Poverty. The route out of poverty is work.
Yeah.
So the government need to support those that want to work,
hmm
have a better
Mhm.
wage.
I recently came across a program called Work Well. They meet with people initially to determine what benefits they're on, what they could be on, and making sure that as they pursue a work opportunity, it doesn't make them worse off.
An example, story of a class and poverty. It's too poor to be sick. The cost of care in a working class life. Let me tell you about Darren, a delivery driver from a council estate in Sheffield. He's in his late 40s, has diabetes and early signs of heart disease, but rarely sees his GP. Why? Every time he takes time off for a checkup, he loses income and is already struggling to cover rent, eating and food for his kids. Last winter, Darren collapsed at work. His blood pressure was dangerously high. When asked why he didn't come in sooner, he said, "I knew something was wrong, but I can't afford to be ill. If I stop working, everything stops." So his experience it's backed up by data.
hmm
Men in the most deprived areas of England live 9.7 years less than the least deprived. For women, it's 7.9 years less. People in low-income areas experience chronic illnesses 10 to 15 years earlier, especially heart disease, diabetes and COPD. And many avoid care altogether. Over 30% of working class adults delay appointments due to work or travel costs.
hmm
So Darren's health wasn't just shaped by genetics, it was shaped by postcode, income, and an impossible choice between getting and getting by.
Exactly.
I like
Perfect.
that.
Yeah.
Yeah. I'm sure
Yeah.
there are many Darrens.
That perfectly encapsulates what we've been talking about in this episode. People's situation, where they live, the opportunities they have or don't have, all work together to result in an outcome, right? I think that's a perfect example.
Hey, Dr. Jeremy, we've come to the end at last.
Yes.
To this grueling episode.
Yeah.
Yeah, finish off.
Okay.
With our labels and misconceptions. We've had our stories.
Yep.
Give me a label misconception, please.
The label and misconception I wanted to talk about was, again, this idea of equity versus equality. I think a lot of people are confused about what equity means. Some people think it means unfairness, like somebody's getting something I'm not getting, but that's really not true. Equity is really about safeguarding the people who need it the most.
Is that your label?
The label would be, equity. And the misconception is that it means unfair, giving more to one person versus another.
Okay.
And I think that's a misconception. I think it really is about safeguarding the people who need it most to get equality of outcome. Sometimes equality of opportunity. Sounds great. And what about you, Val? What's the label you want to talk about in misconceptions?
I'm going to use it again. My label is hard to reach.
Mm-hmm.
So we look at the three stories. We look at the people of colour, disabled people, working class families.
Mm-hmm.
They're often labelled hard to reach. No one's hiding.
Yes.
They're not hard to reach. What might be hard to reach is accessing your services. If they've got to catch a train and a plane to get there to be seen, that's hard.
Yeah.
Resources need to be accessible.
Yes.
My misconception is that the NHS treats everyone equally.
Mm-hmm.
I think they do, in a sense, but
we're seeing unequal outcomes.
The outcomes say differently.
People have different opportunities.
We can't disagree with the outcomes.
Mm-hmm.
So when you present that, you say, wow.
Yeah.
We're not all treated the same. Our outcomes are different.
Yeah.
Okay, that's it.
Yes. Okay. Have a great weekend. Yeah?
Yeah.
Okay.
That's my sentence.
Okay.
Rushing me now after about 2 hours of episode.
I know. You've inspired me to check out Planes, Trains, and Automobiles. I haven't watched that film for years.
Thanks.
John Candy. Those aren't pillows. Yeah.
The most marginalised often carry the heaviest health burdens, not by chance, but by design. Next week, we ask if we know the causes and have the data, why aren't things getting better? Thanks for joining us for episode 3 of our 6-part series on health inequalities. We hope you'll join us. Goodbye from me, Val Barrett.
Dr. Jeremy Anderson.
Goodbye.
Thanks, everyone.
Link us on our socials and share us. And I forgot. Oh, God, I forgot. Yeah, we're on Twitter, we're on Instagram, and we're on Facebook.
We're everywhere.
For now.
Okay, bye.